Coming up on this episode of Healthy Longevity.
Sleep plays a critical role in restoration for humans. It's the only opportunity for housekeeping that we get.
It's during sleep that the immune system goes to work. If we don't get good sleep, we end up dying younger of a lot of diseases.
If people don't sleep well, the likelihood of having cardiovascular disease in the form of coronary artery disease, atrial fibrillation, hypertension, that all is higher.
Can you share some of your best sleep tips?
Having at least an hour or so of the absence of bright light, having some kind of a wind down routine, and going to bed when you're sleepy is probably one of the most useful things one can do to have a healthy circadian rhythm.
If you hit the snooze button 5 times before getting out of bed, consider this your wake-up call. Join in to listen to my conversation with Dr. Chopra about how you can optimize your sleep, avoid chronic diseases of aging, and feel great every morning. Welcome, Sahil, and thank you for joining Healthy Longevity.
It's my pleasure. I'm super excited to chat today. We've chatted multiple times in the past and excited to be here. Thanks for having me.
I'm delighted because I think sleep is paramount. It outranks everything as far as I'm concerned with individuals. And it's always something we focus on. So have an expert like you. And I understand that you're known as the chief sleep giver at Empower Health. Tell me how you came to specialize as a sleep physician and develop Empower Sleep.
Yeah, it's really been a journey. So, I have pretty humble beginnings. I started off as an internist, did residency at UCLA. I worked as a hospitalist for 3 years thereafter, doing primarily inpatient medicine. And during that time, I really loved working, taking care of critically ill patients. So I ended up doing a pulmonary critical care fellowship and luckily matched at Loma Linda University. And for anybody who's, listening, they might be aware that Loma Linda falls into what's called a blue zone. And you could see there's a sense of wellness in the organization, in the culture, in the foods that you eat. And we would take care of people in the ICU who were in their 80s and 90s. Which, if anybody was at a county hospital ICU, that's something that you would sort of never see. So the idea of wellness, I'll just put it in quotations, longevity, healthy living, all that became very interesting. So that seed was kind of planted. And then as a pulmonary fellow, we took care of this condition called sleep apnea, obstructive sleep apnea or central sleep apnea. And that was sort of my link into sleep medicine. I was really curious about all of these wearables that were exploding in the 2015, 2016 time. I saw how clunky sleep testing was, sleep assessments were. And I'm sure you've seen this where, people come to you saying, hey, my sleep isn't that good. You do then a sleep study and all you get is there's no sleep apnea.
Exactly.
Right. And that was
very frustrating, actually, because that wasn't the only finding. And if you get their story, it's so variable. So, not everybody is a lot of people do suffer with sleep apnea. And we've caught even a chief of cardiothoracic surgery at one of the major medical centers in New York who would sleep 12 hours a night. And when we studied, and he had bad heart disease too, by the way, and he would complain about being exhausted. Turns out he had sleep apnea, both obstructive and central. So that was a good catch. But in general, it was frustrating to send people to a lab. First of all, you get wired up and it's not much fun. And you're disturbing the sleep because obviously we know that we're not sleeping in our own bed, we're full of wires. And you have very little to show for it afterwards.
Totally. 100%. So all of those things were sort of happening. And I was like, man, how come sleep medicine doctors aren't looking at sleep holistically? And so I decided to do a sleep medicine fellowship. I luckily matched in Boston at Harvard. And those guys just opened my eyes to what sleep medicine is supposed to be. And one of the things that Dr. Robert Thomas, he's the program director and he was a really mentor to me. one of the professors in the division, he basically seared into the brains of all of the fellows that your job as a sleep physician is to be someone who understands physiology when humans are sleeping. And when you think of it that way, then it like unlocks a whole dimension of like what's happening in the metabolic system, what's happening in the brain, what's happening in the eyes, what's happening in the cardiovascular system, what's happening in the hepatobiliary system when one is sleeping. And this idea of improving people's sleep is not just getting them a good score, but but like making sure all of these sort of micro processes are happening in alignment with your circadian rhythm and as healthy as possible when someone sleeps. And like that was just like so fascinating to me.
It
Um,
completely resonates with me because one of the reason to start this was to say, how come we don't pay attention to the entire organism? And as you know, it's during sleep that the immune system goes to work. If we don't get good sleep, we end up dying younger of a lot of diseases, and whether it's heart disease or diabetes. If we mess up our sleep because we're jet lagged, like people who have shift work or flight attendants, they don't have healthy bodies, and many of them suffer because actually genes turn on and off where you live. And if you move where you live, you induce early at Harvard. It was studied at Harvard, at Wisconsin. If they change the clock time and make it move ahead or back, you get diabetes with that. And the older you are, the less likely it reverses too quickly. So it doesn't. So it's you're absolutely right on the nail that this is a whole body process that needs to be optimized.
yeah, and just to sort of echo what you're saying, from out of the Wisconsin nursing cohort, like they've actually discovered that women nurses who were shift workers had a higher prevalence of breast cancer. So there's like a carcinogenesis component to this too when someone's circadian rhythms are so disrupted. So yeah, it's just really fascinating of like the width and depth of how complex and how important sleep is. And sometimes it's unfortunate that in traditional sleep medicine it gets sort of pigeonholed into just obstructive sleep apnea and
I think
medications.
that's
And
because it's, that is something to measure, and people don't, like really color outside the lines in medicine because they're so busy taking care of sick people. They just focus on something that they could address, like the chief complaint, as opposed to looking at the whole human being and understanding that each of us is unique. And even myself and my identical twin, we're not alike. It's what drove me to understand the choices you make in life are going to affect expression of genes and how you live life and the illnesses you get or don't get. That's the hope. But we're completely synergistic that way. It sounds exciting. And did you yourself, on a personal note, have or know people in your family that had sleep issues and would keep asking you questions? No. So you came to it because you had a powerful mentor and it opened up your eyes to it. I have a similar story at NIH. My powerful mentor was a guy named Dr. Lynn Lorio, and he made me think about how to think about
yeah,
people, as opposed to just automatically falling in line and doing standard of care, which is conventional medicine. And it's, reactive instead of proactive.
yeah, I know totally.
When I,
It's amazing how we have this opportunity to sort of stand on the shoulders of the people that came before us.
Absolutely.
And,
Yeah.
so I'm really grateful to all of them.
Yale was like that too. I mean, we used to talk about Harvard, but we pretended we didn't know where it was really. No, only kidding. Yale was a big research center. In fact, it had per investigator as many more grants than any other university. And I had mentors there as well as NIH that made you look at people. That's one of the reasons that drives me in clinical investigation, and figured out things based on looking at patterns. And I think that's what I was able to do. And it sounds like that your interest too. In my case, I used to put nutrition, then exercise, then sleep in that order. Like actually it was exercise, nutrition, sleep. And I realized very early on in my work that that wasn't the right order, that the right order was sleep, nutrition, exercise, and that sleep trumps everything. In fact, when people get sick or when people have worked too hard and they tell me, oh, they're going to get up at 5 and get to the gym and they're going to make sure they fit that in, I say to them, no, actually, I want you to sleep in. I don't want you to disturb your sleep to go work out because you're going to undermine your working out and your health. Um, So your wake up call sounds like it was basically really having your eyes opened, both seeing healthy people at Loma Linda, which is fabulous. I'm envious of that. And then going to Harvard and seeing that this was a real field that needed to be addressed. And you were interested in jumping into that field. Well, I'm impressed because it's very hard to find sleep doctors who are holistic. You know, they tend to do what they do well. Even over the years, I've tried to find companies that can measure people's sleep at home, thinking that was more physiologic, that I could get a sense over a few days. And I know when I met you, that was one of the things that impressed me, you know, that it was exactly what I had hoped for, because these companies would come about and then they disappear. And it was very frustrating in some ways because I wanted answers. Let's talk about a little why sleep is so critical to good health. You know, what do you think it boils down to?
Honestly, we probably don't know for sure. Like, a lot of what our understanding is about the importance of sleep comes from our understanding of what happens to people who are sleep deprived, whether that is intentional sleep deprivation from an experiment or sleep deprivation in some capacity because of a disorder like obstructive sleep apnea, restless legs, insomnia, something along those lines. And what we learn from intentional sleep deprivation or from any sort of pathologic disease is if people don't sleep well, the likelihood of having cardiovascular disease in the form of coronary artery disease, atrial fibrillation, hypertension, that all is higher. Cortisol dysregulation is higher. Growth hormone levels are lower. Circadian rhythms, if they are misaligned, results in a dysmetabolic state. The possibility of higher risk of cancer. There is a link, a six-fold higher likelihood of people who have disrupted sleep, particularly a reduction in deep sleep. They have a higher risk of cognitive decline in the form of Alzheimer's disease. So that's kind of our learning from pathology. And from that, we've sort of worked backwards to understand, okay, sleep plays a critical role in, let's just use the brain as an example, memory consolidation. Sleep plays a critical role in that. The REM sleep plays a critical role in emotional stability. During stages of deep sleep is when blood flow to the brain is at its peak, and through what's called the glymphatic system in the brain, these beta amyloid and tau proteins are filtered. So deep sleep plays a big role in possibly the prevention of Alzheimer's disease and cognitive decline. From a cardiovascular standpoint, we know sleep plays a critical role in helping people drop their blood pressure and their heart rate during sleep. During sleep, we know that the GI tract slows down. And as a result, recovery of the epithelial lining in the GI tract happens. So there are all these physiologic processes that happen during sleep. And if you had to just put it into a sentence, sleep plays a critical role in restoration for humans. It's the only opportunity for housekeeping that we get. That's kind of the primary functions of sleep. And then as you mentioned on the immune side, there's so many studies where you take someone, administer them a vaccine, and you give one person a regular opportunity for sleep, and you give someone 4 to 6 hours of sleep. The people who had less sleep don't respond to the vaccine as well as people who had an adequate amount of sleep. So there's just a ton of bits and pieces that we've sort of collected, but really at the end of the day, it's a housekeeping process for our physiology that allows us to restore and start the next day.
Yeah, I always find it interesting when people answer our questionnaire. And one of the questions we ask is about sleep, how much they get, if it's disruptive, if they have a hard time falling asleep, or they wake up often, something that starts happening midlife a lot, I think because of hormonal and metabolic changes. And a lot of people will say they don't prioritize sleep because they figure they'll get as much as they need after they die, and they want to make the most out of life. And so I'm not sure I understand why people can't prioritize sleep or don't choose to, or even why physicians, although I think I'm closer to why physicians don't really delve into sleep. I don't think physicians have the wherewithal or the training, and it's elusive to them as well. It's not like they sleep well. We have our own issues. Why do you think people don't really know how to prioritize sleep or don't care to?
I think the biggest, again, this is my opinion, I think the biggest reason is if we solely build up sleep debt, there is no pain involved in that. Like if there is pain, we prioritize, like I need to fix pain. And sleep is one of these really unique things that it's like such a physiologic necessity. But when it is absent, only in the extreme stages do we have like substantial pain.
Why do you think that's fascinating? Because I've recognized that when I see patients in a very minimal way, not like you, I'm not a sleep expert, but I recognize it in when I see that people don't get enough deep sleep. They sleep for 9 hours and they get maybe 9 minutes of deep sleep or none. And they tend to divert to REM. And I see these distinct breakdowns between people. Like the people who get deep sleep can sleep for 2 hours and get an hour and a half of deep sleep and feel great. And I know people who work on that and they know that they get the deep sleep, they're fine. Whereas other people suffer when they can't get deep sleep. But it's really amazing that a vital body function can be ignored and yet you don't feel any pain from it, or you don't feel pain that you recognize from it.
100%.
Yeah.
100%. And I think
That's brilliant, actually. Yeah.
we are like we compensate, or at least we think we compensate
Right.
well, right? And we don't know that we were compensating poorly until we treat the underlying sleep issue. And you probably have heard this in your clinic so many times where patients will use this metaphor of like, I feel like the fog has been lifted.
Yes.
And they just never knew that their judgment, their how they were feeling was so clouded.
Yes.
And it's sort of like slow, chronic, insidious, and people just tend to compensate because they don't know it better.
Yeah, no, totally. I think an analogy for me that I've experienced, but also other people who travel, sometimes I travel extensively or I worked on both coasts. And I only realized that I was sleep deprived and I was suffering until I had like 3 weeks or more in my own bed at home. And then I realized that I woke up and life was brighter again. And because you slowly decompensate without really, and the same thing happens at every level in the body. And that's what, in fact, this patient I was going to, think about studying travels incessantly. He can't even really pinpoint where he lives. I mean, he has a home in 3 different countries and works remotely everywhere, works hard. And he doesn't understand, even with a GLP-1 and other treatments, why he's not losing weight. And I know it's because he's not sleeping. He has disorders of sleep. Of course, it just happened. So it happens to be top of mind, but it's very common. And he's 48 and he's paying a price for it because he doesn't understand why his body won't respond to kind of interventions that should work for him. And that's so common.
Totally.
Can you take us to shift a little bit, but into the main, I'd love to hear your main work in Empower Sleep and how the sleep image program actually works. I know it starts, having experienced it myself and enjoyed it actually. It starts with an at-home test. What do you do from there? How does it work for an individual that gets referred to you or wants to learn more about their sleep?
Yeah, I think I'll take a step back for just a second if anyone doesn't know how like traditional sleep testing works, it's rooted in this idea of like a study either done in a lab or at home, and it's just a one night snapshot. And that one night snapshot ends up going to a sleep doctor who views it, signs off on it. So patients don't really know the results of that data collection for weeks or months until they've actually received the report. And what we've tried, and then it also, this one night sleep study also then assumes that sleep is static. Sleep is not dynamic. And if any of us have ever worn a wearable device, a Whoop, a Garmin, an Aura, like we can see that, hey, my sleep is different night to night. with different behaviors, different interventions, different sleep timings. There, like sleep is such a dynamic. Um, it's so dynamic and resilient that different things influence it in so many different ways. So the idea of a one night snapshot does not make a lot of sense. So what we tried to do, and it kind of stumbled upon this by accident, where we have patients do longitudinal sleep testing. We give them a home sleep testing device, a ring, and we allow them to test on a nightly basis. And using that data as it flows into us, we built software so that data can be processed and patients can see their results every morning in the app. So now you have like this medical grade technology that has been consumerized the same way like an Oura Ring or a Whoop or a Garmin or an Apple Watch has. And this allows the patient to sort of see their results in real time. They can get some personalized feedback and insights through our AI engine. And there's always the support of a doctor to help give the patient some kind of guidance of like what to do, what not to do, or what will be some different therapeutic options. So it basically allows, and I picked this up from you, like the idea of like N of one care, using their sleep testing biomarkers across time to get people who have a sleep disorder to help them optimize their health from a sleep standpoint.
So great. So it starts with this in-depth at-home study where you wear a ring. It's a little larger than the Oura Ring, but it didn't interfere with my sleep when I tested it. I had other people test it too. And then it gave me some insights. My sleep happens to be pretty good unless I'm truly stressed, which, sometimes happens. But in general, I default to deep sleep. So even if I have short amounts of sleep, but it definitely affects me. So there was a period of time I was using therapeutic plasma exchange about 5 years ago for about 3 months of doing it. My biological age had reversed by 15 years.
Wow.
Then in the next 3 months, I was doing a new startup. We're translating the information to consumerize it and make it available to people online and through an app so that people can get insights into their own health. Because I too believe wearables are game changers. And I started sleeping 4 hours a night because I had to do this work until 2, 3 in the morning. And I had to get up at 6 and get going for the day. And I not only lost those gains, but it went even lower.
Wow.
So my age aged rapidly over 3 months. And that wasn't much fun. And I was still doing therapeutic plasma exchange every month for 6-month period. But it was sleep that was the defining change in the second 3 months that I wasn't optimizing. And I knew it. I made a choice. But it was an interesting biological test, at least for me as an N of one. So it sounds like that's a great place to start. Once you get that information, where do you go from there? Like, how does your system work to help people, get back to sleeping or get great sleep for the first time in their life? Because many people have sleep disorders even as children, and they know it goes way back.
Yeah, no, 100%. And it all comes down to like, it depends on what's wrong, right? Like this idea of like cookie cutter care doesn't really exist at Empower Sleep. And it depends on what's wrong, what biomarkers are abnormal. And depending on like what is abnormal, the care pathway will be devised according to that. And depending on how you respond, the care pathways will be dynamic because not everybody is going to respond the way that we read in textbooks. So, for example, let's say someone has, I'll just use sleep apnea as an example. Sleep apnea can vary from like mild to moderate to severe sleep apnea. And even within that, the question is always like, is it during non-REM sleep? Is it REM sleep? Is it positional? How low does someone's oxygen level drop? How is the response of our autonomic nervous system to these apneic events? So there's a lot of like nuances even in this like bucket of obstructive sleep apnea. And depending on what we find, let's say you have someone who has minimal symptoms, mild apnea, very scant desaturations, like drops in oxygen saturations. In that situation, I might just even say, hey, John Doe, let's try some mouth tape and nasal strips. And I'm observing that you're mostly a mouth breather, not a nose breather. So let's do some like things over the next 6 weeks to help you improve your nasal hygiene, nasal breathing. tongue exercises, and see and track objectively, like how is that influencing your sleep, and let's track objectively, subjectively how you're feeling. So I wouldn't like jump to a CPAP machine because somebody got labeled with the diagnosis of a sleep apnea, obstructive sleep apnea. If someone has, say, moderate to severe sleep apnea, we, depending on the symptoms, the comorbidities, like if someone has atrial fibrillation and cognitive decline in the setting of of obstructive sleep apnea, I would approach that more aggressively than I would who doesn't have any other comorbidity. And so it kind of like depends. And if we want to
You
talk
start
about,
with the lowest hanging fruit. You want to correct what we think of as habits or lifestyle. And so you want to change, anything from taping the mouth to by observing that someone's a mouth breather and seeing if that changes their and reverses their mild sleep apnea. And depending on the severity, you might push it faster, further, depending on their response. Not dissimilar from the way we approach people, because obviously lifestyle, the choices of eating and working out and can affect different people in different ways. And if we see that in changes in glucose or hormones, we can first tackle it with the lowest hanging fruit, which is basically, when are you going to sleep, and what's your, sleep hygiene, and do you turn off kind of interactive, devices before you get into bed? Can you try Epsom salt in a bath, or, not eat for a couple hours before you go to sleep, which we find makes a huge difference metabolically as well. So I'm totally, understand that. That makes sense. And what do you consider, just this is a technical question that I'm curious about, what do you consider a mild drop in saturation, desaturation? Like, is that something that, you usually are 97, 98 and you drop down to 92, 93, or what is your usual percentages? Is there a number that you assign to it?
yeah, I think anything that's a greater than 5, 6, 7% drop is a significant drop. But it also depends, like how many of those does one have?
Got it.
Because let's say somebody just has like 3 or 4 of those, and the rest of the night is relatively pristine, I wouldn't really jump. I wouldn't make any conclusions. But if someone has like a higher number of these events, with these like significant drops, I would be more concerned. And right now, like the American Academy of Sleep Medicine doesn't really give guidance on like how to quantify, like the obstructive sleep apnea diagnosis does not take into account all of these different things. Sort of like the diabetes diagnosis is based on A1C, but there's so much more to diabetes. Similarly, this like obstructive.
And like you, A1C is certainly complicated because it's meaningless in a way. I've always had a great A1C under 5, but I have very big variations in the past in glucose. It would go high, go low, but an average of 100 days tells you nothing. It just gives you a sense. But we know even if you're 5.5 or 5.6 and you're headed towards prediabetes and diabetes, that you have a lot more variation in glucose than you're aware of, or you're insulin resistant, or any one of those combinations. So I talk about that a lot, the meaninglessness of the getting your hemoglobin A1C under 7, which, by the way, as you know, is still diabetes, right? 6.5 and up is diabetes. So it's very loose. I don't know, you may agree or disagree, but I think that the problem is we deal with so many sick people and we have so many questions that aren't answered, that we don't know, that we tend to move to the lowest common denominator and do what's the simplest instead of really looking at nuance. And that's a problem of conventional medicine and how many sick people we have to deal with and the cost of caring for people. You don't invest in your sleep unless you know it's such a serious problem you're suffering, as you pointed out. Many people don't suffer initially. They don't realize that the other diseases they have can be directly correlated with poor sleep.
Yeah,
So I
no.
think that was a fabulous, brilliant point. Just quickly, you mentioned Aura and Whoop, and I'm a big Aura, Whoop, and believer. Apple Watch, it's great to collect the data. Do you integrate that into your system, or is your an independent system where you're collecting your own data and then reviewing what other people might have?
Yeah, no, we do. Patients can connect in the app, Whoop, Garmin, Aura, 8 Sleep, Apple, with Empower Sleep, and then the cool thing about that is it gives us the data that they're getting from their consumer grade device, and it'll immediately give us like 6 months of like retroactive data.
which is
So then,
fabulous.
which is like really meaningful. Right now, you can have like a very meaningful conversation with a patient to be able to look at like longitudinal data from like a few months ago. But then the other really exciting thing is it allows the patient and us to help the patient draw some directional correlations of like, I don't want you to have to, there's a little bit of friction in putting on a ring and doing a sleep study every night. But if you have a device that you wear all the time, and you can now draw a directional correlation of when I see these numbers on a consumer grade device, this is what it kind of means from a medical grade study because they were done simultaneously across time. It allows them to then sort of keep their sleep in check of, okay, this is what I need to see to ensure like my sleep is actually pretty healthy.
Yeah, great. And exactly. I feel the exact same way. It's funny because I think we've a sense that trends are really important. One absolute number is kind of meaningless or infrequent. So we tell patients the exact same thing. Let's get all your data. Let's look at what you've been doing over the last few years. I've had patients who come to me after collecting data for 30 years and having spreadsheets. And the good news is that you can show them exactly when they started changing. And I love that because you can draw blood, for example, at the same time, same thing with sleep studies, I bet, and send them to two different labs and get two different numbers. And
Yeah.
you can also interpret it differently. So looking at trends and teaching a human being how to self-evaluate, I think is a gift of health because there are never going to be enough clinicians, doctors, or physician associates or nurse practitioners who can actually help one-on-one. We run very bespoke systems, you and I, and yet everybody needs this help. So to me, it's a way of changing the future health of this country and the world if we can figure out a way to transfer that knowledge. So I love that idea that you're able to do that and make correlations that people can use. So moving on, for those listeners who want to sleep well tonight, can you share some of your best, I realize they're general, but best sleep tips so that they can use the night to wake up refreshed and energized and ready to go? Is there anything that you find that works across the board or in general or even in the majority of people or even not? Whatever you can add, I think people, my listeners, would appreciate.
Yeah, and I'm sure these are all things that people have heard before many times. If I had to say like what's like the two or three most important things that will help somebody, um, is one is from a circadian standpoint, uh, like optimizing your circadian rhythm, and just our circadian rhythm is what regulates our daily clock. There's a biologic day and there's a biologic night. And we want to be doing the processes of nighttime during the biologic night, and we want to be doing processes of the daytime during the biologic day. So what that means is like if we can help facilitate us going to bed and us waking up and with the help of darkness at nighttime. So having at least an hour or so of like the absence of bright light, having some kind of a wind down routine, and going to bed when you're sleepy. And then in the morning time, getting exposure to bright light for 10 or 15 minutes is probably one of the most useful things one can do. One can do to have a healthy circadian rhythm.
Is that, and that reflects like you're going to bed pretty much at the same time if you can, and waking up at the same time if you can, or close proximity. I believe in that. A lot of people I know use blackout shades to make sure the room is as dark as possible. They try not to watch TV and play on their phone or computer. I like to tell people to use an old fashioned book, but it's that tip I think is magical. I don't think it's melatonin plays a role, but I don't think it's the key role. I think it's resetting your body thermostat, if you will, and that makes sense.
100%. And then the second thing that I think is like probably the most equally as important is equalizing the time you sleep to how much time you spend in bed. So like if someone is like say a 7-hour sleeper, please don't spend 9 hours in bed, because once we start doing that, then what starts to happen is we start associating the bed to a place of wakefulness. We start associating the bed to like doing other things for an additional 2 hours. When that over time sort of increases the risk of someone to develop insomnia type of symptomatology, whether that's sleep onset, sleep maintenance, or early morning awakening. So having good guardrails of like when to go to bed and when to wake up and not letting that be too wide is critical. And like we see this all the time where people who were really good sleepers and then they retire and then their sleep kind of falls apart, where they start taking naps during the day, they start spending too much time in bed, and then they start developing symptoms of insomnia. So like the two most important things that I tell all of my patients is have a good, sleep onset and wake up time should be intentional with darkness at night and light in the morning, and sort of try to limit the amount of time you spend in the bed, try to equalize it to how much you sleep.
Makes a lot of sense, and maybe don't retire. So I think it becomes a vicious cycle if you try to do that. It's an interesting point I find fascinating. There are a few other things people might enjoy doing in bed. So you might need a couple of extra, a little bits of time, but that's of course personal. And it's, maybe not, the bed doesn't need to be used. Another concept I've heard recently too in the last few years is sleep divorce. I find it intriguing, and I wonder if it's a good thing, a bad thing. I think it's probably individualized, where people don't sleep well with a partner in bed. It's disruptive. They're very light sleepers, apparently. And so they end up sleeping in separate rooms, which I don't know how conducive it is to the relationship, but maybe it is better for sleep. What are your thoughts there?
Yeah, I kind of just defer that back to the patient. And what I'll sometimes do is just have them collect some data so that we can have an educated
Great
conversation
way
about
to do it, right? Exactly the way I would do it, because you want the data. Otherwise, it's just your opinion. And yes, you can test your opinion by changing things. But this is where the self-help part kind of, I think, comes back to haunt us. I think we're so complex. Both of us agree we don't know what we don't know, and figuring it out requires insight that I think goes beyond even our training. Is a beginning point, and it's the experience we have in looking at these individuals who can't sleep or, can't, like are not healthy and have other issues that we need to optimize, that I think makes a difference. One question, I missed this, but I wondered your thoughts about restless leg syndrome, because I'm sure there's lots of listeners who might struggle with it. I've had patients we diagnose. I understand there's a genetic component to it as well, and we've seen that. I've used some supplements to great effect. I've used other interventions, like particularly with middle of the night awakening at midlife, that can sometimes involve restless leg. I don't see it that commonly, but I do see it. I would see several cases a year. What is your system? Can you advise people on that beyond apnea, whether obstructive, which is common, or central, which is deadly and must be diagnosed? So that, where would you put restless leg or any other syndromes? Is there a way to help people directly?
Yeah, no, 100%. RLS, in these situations, we want to make sure that one does not have obstructive sleep apnea, because RLS symptoms will be exacerbated in the setting of other sleep disorders. That's step number one. The other things to look at is making sure that one is not taking any medications that could exacerbate RLS symptoms. Antidepressants are known to do this. Benadryl is known to do this. So it's not uncommon for someone who has RLS symptomatology, who then was prescribed something for sleep onset insomnia, or is taking something over the counter for difficulty with sleep onset, like Benadryl or a different sedative hypnotic, that could then exacerbate restless leg symptoms. So looking at the medications is important. Making sure they don't have sleep apnea is important. And the other thing, from a blood biomarker standpoint, what we've understood is restless legs happens when there is a deficiency of brain iron. And one way to understand what the overall body iron stores are is we can measure a ferritin and iron saturation. And if someone has low ferritin levels, that becomes then a therapeutic target of like, I need to get this ferritin over 100. That's what is recommended in the guidelines. A ferritin of greater than 100 before trying to sort of throw a whole bunch of like prescription therapeutics into
Wow.
the equation.
So I haven't heard 100. I've heard 50 or 80, even 30. That time that I described to you that I had, poor sleep and even the therapeutic plasma exchange did not help with aging or optimizing me. My ferritin was 4 or 5.
Oh
And I had a
wow!
lot of symptoms because I had donated blood every month to test myself, like, because I'm a big tester first, because I want to understand, everything to the best of my ability before I invite other people to try things. And then I've been talking to people about iron because I've heard this before, but I didn't realize it was brain iron and that you want a ferritin of over 100 because I start worrying. I know it's not a ferritin of 100 that someone has hemochromatosis. And, when I see, does high ferritin with hemochromatosis where you hold on to iron genetically, does that also affect sleep? Is it the both ends of the spectrum, or largely you try to drive ferritin over 100 because you've seen a difference in restless leg?
These are two different scenarios. One where you have restless leg symptomatology and you have low ferritin levels. And we want to shoot to a super therapeutic dose because getting ferritin across the blood-brain barrier can be a little bit challenging.
Oh,
And
good to
the
know.
one will like iron metabolism is such that it will normalize itself over time. But to treat the acute problem, we want to shoot for ferritin that is super therapeutic transiently. And the hemochromatosis side, I'm not aware of any sort of restless leg type of biology, symptomatology disorders that are linked to hemochromatosis. It's mostly of a iron deficiency.
Right.
But like this sort of transient, because how iron metabolism works, we should be able to lose it over a period of time rather than like holding on to it because of a genetic disorder.
So it goes on. Yeah, hemochromatosis, the main issue there is buildup of iron in the organ systems, whether it's the heart, the liver. But you're relating the super therapeutic levels of ferritin over 100 to help restless leg symptomatology, not necessarily the genetic trait or variant for restless leg, but people who seem to suffer from it, besides taking drugs to help insomnia, ironically, like Benadryl or over-the-counter sleep meds. Excellent.
And then
Yeah.
if that doesn't and then in addition to that, then you have these like gabapentinoid type of medications, narcotics, and now there's actually these like really unique solution that came out a couple of years ago that was FDA approved. It's called it's a nerve stimulator that you put on your calf, and you go to sleep with it. And basically, what it's doing is it's mimicking the peroneal nerve, the legs, the nerves of the legs, to think that your legs are moving. So it's a subtle stimulation that mimics. It tells the brain that your legs are moving, but they're not, and it helps mitigate symptoms. And it's shown uh, to have great outcomes even over 3 months, 6 months, and 9 months. So that's pretty.
Wow,
So
that's interesting.
it's cool because it's a non-pharmacologic modality for a problem that is like pretty common.
Oh, I love it. One quick question. What percent of people do you think as they age get sleep apnea? Is it virtually everyone or is it a vast majority?
Uh, Above the age of age is a risk factor. As we get older, prevalence goes higher, and above the age of 50, at least 10-12% people have it. As we get older, that it's kind of like a hockey puck, and the prevalence goes up in a non-linear fashion. So above the age of 75, it's probably close to 15 to 20%.
Wow. We don't probably have time to dig into this, but I've had a lot of folks talk to me about their children's sleep disorders and what to do. I've tried things like magnesium trionate, obviously the usual hygiene stuff, taking a bath, doing all of that. Um, do you see children too? Are you able to evaluate teens and young children?
Yeah, we totally can,
Oh, excellent.
and there's a pediatric ring, so we can look at kids the same way. And for kids getting into a sleep lab, it's like a 6 month wait.
Oh, I don't even like them going. Like, I wish they'd shut down sleep labs. It probably would disrupt business as usual in conventional medicine, and most people aren't free thinkers like you are, an entrepreneur, and that's a lot of work. So congratulations. Um, to wind up, I actually read a quote from you that I love. You said, "When I look at my children, I see the reason why we must push the frontier of health span." Is that something you recall saying? And I'd love to know where that came from. What was the motivation for that?
So we have three kids. We have three boys, 8, 7, 2, and I think it's like our responsibility. I feel like it's my responsibility as a parent to be around as long as I can, and uh, give them the habits and tools so they can be around as long as they can for their kids. And uh, and I think like we've been given this privilege to be in the world of like medicine, and we have a choice. Either we can I can go work at Kaiser and like be like an HMO doctor, and there's no disrespect to that. It's just like either I can do that and be in confined to a system, and live within a cubicle, or I can sort of like fly and do things and like explore and try to make a change in the entire system. So eventually it makes it to the cubicle. And if that happens, then like how I feel for my kids, like they can do for themselves and their children.
I love
So,
that. Yeah.
it didn't, it's just sort of like a belief system more than it is like a quote that I sort of said to someone in some presentation. But I strongly believe that being in healthcare is a privilege. And, in India, it's not uncommon, like at least in like Eastern culture, like people look at physicians as like godly figures. Like they're people who have the wisdom and the blessing of God to help their patients, whether you're a surgeon or an internist. And I think we don't realize that until we are on the other side of the table. And I've had, so many experiences where very dear family members have passed away at a young age, that I've had the opportunity to see what it's like to be a patient, many times. And I think it just humbles us and it makes us want to become better clinicians, better doctors, better bedside manner, more intelligent, like all of the things, right? And so I strongly believe like we have this opportunity and privilege to like make the world a better place. And if we can help someone live a better life, like that's like the highest karma that I can provide sort of back to the community.
You've given me chills, and I completely agree. I think people ask me how I stay passionate after so many years and working hard. I feel like it is a privilege and an honor. You're getting inside of someone else's brain and body, and you're there. And I've had patients tell me private, secret things that their partners don't even know. And so it does feel like an honor. It's a way of helping people be all they can be. And it's a gift if you can do it. And if you can do it outside the confines of a cage or a cubicle, because that's the system, the standard of care, which is not a fit for everyone, I think it is even more amazing. So I honor that. And I completely see it exactly the same way. In fact, I can tell you about my own son, who I've wanted to refer to you, who we've now been working on his sleep issues. He started in childhood as somebody who would love sleep, go to sleep at 8 and need a lot of sleep, as opposed to my other son. And we've recently realized that he doesn't get enough deep sleep. It really frustrates him. He works hard, but he has a balance in his life. He's good that way. He's a lawyer, actually. And even though we doctors sometimes have quasi feelings about lawyers, he's a good one. He's a litigator and he cares. And I've put it on myself to help him get sleep. He's going to be one of the first people we'll look at. He had the mild apnea, and they're now fitting him out for a bridge. We've tried CBD, CBG, you name it, we've tried it. And it's working to some degree, because he's now getting more and more deep sleep. But the need for long hours of sleep, I'm talking 10, 12, 14 hours, I think comes from the fact that he didn't feel rested, and also his sleep pattern instead of getting deep sleep early at night, he gets it late, like late in the night, early morning almost, and that is, I think, problematic too, because it keeps you sleeping in. And I don't have an answer for that, but I'm hoping you will.
No,
So
I think like, so the way that I would, not to, I know you probably have to jump, but very quickly, in this situation, I would do like a home PSG. Like what you're describing is someone who has mild sleep apnea with reduced sleep quality.
yes,
There's two kind, like, you know how in heart failure we have heart failure with preserved EF and you have heart failure with reduced EF.
yes.
We've been sort of endotyping sleep disorders that same way, where you have a sleep disorder with preserved sleep quality or a sleep disorder with reduced sleep quality. And mild sleep apnea with reduced sleep quality, that person, we need to look for other disorders that are beyond apnea. And doing a home polysomnography, like it's a PSG that you could do in a lab, but you can now do that at home. It's very easy to do, self-applied patches and stuff, and that would give us way more insights to understand what's happening from a holistic physiology standpoint, to then be able to come up with a plan of what to do much faster than like this sort of cyclical experimentation of different things.
Good. He's had that one study, but I don't know how thorough it was, but we'll collect it. And I would love you to give us your insight. I also have lots of patients with early Alzheimer's or high risk. And I know they have sleep disorders, and helping them has been an uphill kind of issue, because I think people get fixated on what they need from their sleep, and it's very hard for them to change. So that's another category of people that I would love to help, because I would like to stop dementia from unfolding and keep people as good as they can be. And that's one of the reasons I actually am doing therapeutic plasma exchange, because I've seen outcomes that are very promising to reduce tau and amyloid. And you mentioned that when you said about the cleanup in the, the head, the sleep, and reducing those particles, I think are important. So, but Ron has a question about the efficacy of meditation, which I use.
Oh,
Yeah.
yeah, it's actually it can be quite powerful. The way meditation affects our physiology, it increases parasympathetic tone. And the higher the parasympathetic tone during sleep, the more deep sleep we will have, the more slow wave sleep we will have. And I have some really unique case studies where I had a patient who went to a meditation retreat and was meditating for like 2 hours a day. And you can see like he like doubled his amount of deep sleep for a week consistently. So it wasn't like an outlier effect. Sleep quality was higher. He didn't have any other sleep disorder, but like it just sort of emphasizes like the holistic idea about modulating our autonomic nervous system through breathing, through meditation, can be a very powerful tool to improve our overall sleep health.
Fantastic. Maybe I'll suggest that to my son as well, to not just think about reducing stress, but actually actively meditate. I should think about it too. My sleep quality is usually good, but we use meditation to reduce cortisol impact. When you meditate, you also change the expression of genes that create cortisol, which also puts on weight around the
Yeah,
middle. But this is helpful.
this is a meditation is a very powerful tool, and it dates back thousands of years.
Yeah. And even breathing, like take deep breaths. I have that set on my Apple Watch where, reminds me to breathe, and I love it. It does definitely change the way you feel and think, but now I know it changes the way you sleep. I'm going to think about how to, include that in what we talk about.
No, absolutely.
I think we're a wrap, except that I ask this of everybody that I get the privilege to interview. And I'll ask it of you as well. So if you met someone on a plane or at a party and who asks for here's what you're a phenomenal sleep doctor or a doctor, period. Sometimes you don't even have to define it, just being a doctor. And what could they do to optimize their health? What would you say?
Yeah, I think that for me, it's pretty easy.
I know. I feel like I've laid it out.
Yeah,
Great. I say it too, though. You have to know that I'm in your corner. I really do talk about sleep being the most paramount thing you can address.
Yeah, no, like you make sleep a priority, make exercise a priority, make your nutrition a priority, and make your emotional mental health a priority, right?
Love it. Yes.
It's kind of like you can dig into all of these verticals as much as we want to, but I think like these four things from a very high level are all critically important.
It's the balancing act. And I think the wearables and the way you're approaching sleep to really get the data behind the scene and then look at the nuance is going to make a huge difference for your patients. So congratulations, and I'll look forward to working with you.
No, thank you. Thank you so much for having me. It's been a pleasure.
Same here. And would you like to share how people can find you and social media?
Patients can find us at empowersleep.com. You can sign up. Let us know that you found out about us from this podcast. And you can reach out, ask questions, and we'll be making videos to answer all of your questions.
Fantastic.